Welcome to Chapter 5 of the BCSC Glaucoma series. In this chapter, we'll focus on the clinical evaluation and imaging of the posterior segment, specifically the optic nerve head, retinal nerve fiber layer, and macula. These structures are central to detecting glaucomatous damage and monitoring its progression. We'll explore how to examine them clinically and how to interpret key imaging modalities like OCT and fundus photography. Let's begin. Let's start with a few key points to keep in mind throughout this chapter. Glaucoma tends to damage the inferior and superior poles of the optic nerve head early in the disease, which has important implications for where we look during exams and imaging. While the cup-to-disc ratio is commonly referenced, it's actually a fairly imprecise metric. OCT gives us more objective and quantifiable data, specifically about the RNFL thickness, the topography of the optic nerve head, and macular thickness. Importantly, macular damage can occur even in early glaucoma and might go unnoticed on standard perimetry, but OCT is sensitive enough to detect it. Let's talk about examining the optic nerve head. The best clinical method is slit lamp biomicroscopy using a 60 to 90 diopter handheld lens. This gives us a stereoscopic view and helps us evaluate the contour of the ONH. You can also measure the vertical diameter of the nerve using the slit beam. A normal range is about 1.5 to 1.7 millimeters. While direct ophthalmoscopy is sometimes used, especially in children or less cooperative patients, it lacks the stereo detail we get from slit lamp evaluation and tends to underestimate cup size and pallor. Cup size itself is influenced by the size of the optic disc. Smaller nerves usually have smaller cups, and larger nerves tend to have larger cups. This is especially important because black patients often have larger discs and physiologically larger cup-disc ratios. Also remember, myopes may have cups that appear smaller than they are, while hyperopes may appear to have larger ones. What we really care about is the neuroretinal rim. That's the tissue between the edge of the cup and the optic disc margin. Finally, don't assume a large cup is always abnormal. A cup-to-disc ratio of 0.7 might be perfectly normal in a large disc, while 0.3 could be abnormal in a small one. So always interpret the cup size in the context of ONH size. It's important to differentiate between glaucomatous and physiologic cupping. A large physiologic cup can look like glaucoma, but it may just be a normal variant, especially in patients with a family history or in high myopes. Myopic eyes are particularly tricky since they may have an oblique optic nerve insertion creating an unusual contour. When evaluating for glaucoma, look for early signs like diffuse thinning of the neuroretinal rim. This is especially critical at the inferior and superior poles. Asymmetry in the cup-to-disc ratio greater than 0.2 between the two eyes is rare in normals and should raise suspicion. Also, keep the isn't rule in mind. Normally, the rim thickness follows the pattern inferior greater than superior, which is greater than nasal, which is greater than temporal. If this pattern is violated, it may suggest glaucoma, although the rule isn't very specific. Take a moment to observe the optic nerves shown here. This is a classic example of asymmetric optic nerve cupping. On the left, we see the right eye, labeled A, which shows a generalized enlargement of the optic cup. Compare that to the left eye, labeled B, where the cup appears smaller and the neuroretinal rim is more robust. This degree of asymmetry in cup-to-disc ratio, especially if it exceeds 0.2, is unusual in healthy individuals and should raise concern for unilateral or asymmetric glaucoma. Let's now focus on optic nerve head features that are suggestive of glaucomatous damage. One of the hallmark signs is vertical elongation of the optic cup, which reflects preferential loss of neural tissue at the superior and inferior poles. You may also see an acquired optic disc pit, which appears as notching. This finding is worrisome, as it carries a high risk for disease progression. In advanced glaucoma, you might observe lamina cribrosa striations. These represent structural changes from posterior bowing of the lamina associated with permanent tissue damage. Finally, during progressive cupping, the central retinal vessels may shift nasally, reflecting changes in the internal architecture of the optic nerve head. Here, we can visualize two classic features of glaucomatous optic neuropathy. On the left, in Figure 5.3, we see vertical elongation of the optic cup in the left eye of a patient with moderately advanced glaucoma. There's localized thinning of the inferior and superior neuroretinal rim, with exposure of the underlying lamina cribrosa inferiorly, a hallmark of progressive rim loss. On the right, Figure 5.5 shows striations of the lamina cribrosa in a nerve with severe glaucomatous damage. These striations reflect posterior bowing of the lamina and structural deformation due to chronic intraocular pressure-induced stress on the optic nerve head. This image shows Figure 5.4, highlighting an acquired optic disc pit in the inferior temporal region of the optic nerve head indicated by the black arrow. The pit appears as a focal excavation with complete absence of rim tissue in that region. This structural defect is concerning because it is often associated with a high risk of disease progression and visual field loss, particularly when it develops in areas typically affected early in glaucoma, such as the inferior rim. Alongside structural changes like vertical elongation of the cup, optic disc pits, lamina cribrosa striations, and nasal shifting of the central vessels, there's another critical finding that can indicate glaucomatous progression, one that often flies under the radar. I'm talking about optic disc hemorrhages. These are typically flame-shaped RNFL hemorrhages that occur on or near the optic disc. They're seen in about a third of glaucoma patients at some point during their disease course. Importantly, they tend to resolve spontaneously over a period of weeks to months, which makes them easy to miss if we aren't vigilant. But don't let their transient nature fool you. Optic disc hemorrhages are strongly associated with visual field progression, particularly when they occur at the sites of rim notching. In some cases, they may be the only clinical clue that a patient's glaucoma is worsening. It's also worth noting that while disc hemorrhages are concerning in glaucoma, they're not entirely specific. They can also appear in conditions like posterior vitreous detachment, diabetic retinopathy, central retinal vein occlusion, or in patients who are anticoagulated. So context is key. The take-home point here is this: if you see a disc hemorrhage, always follow up closely. It may be the earliest and only sign that more aggressive management is needed. Here we see a fundus photograph that clearly illustrates the clinical relevance of what we just discussed. This is a flame-shaped optic disc hemorrhage, marked by the arrow, in a patient with open-angle glaucoma. It's located at the inferotemporal rim, which is a common site of neuroretinal rim thinning in glaucomatous eyes. Notice how the hemorrhage hugs the nerve fiber layer pattern, giving it that characteristic flame shape. This finding reinforces the message that disc hemorrhages often arise at structurally vulnerable points on the optic nerve. While subtle, their presence may be the only active indicator that the disease is progressing. This underscores the importance of meticulous optic nerve head evaluation at each visit, especially in patients who may otherwise appear stable. If missed, the opportunity to intervene early may be lost. Now that we've reviewed progressive optic nerve damage and the significance of disc hemorrhages, let's shift focus to the retinal nerve fiber layer, or RNFL. Understanding its normal appearance is essential when trying to detect early glaucomatous change. Under red-free or green illumination, a healthy RNFL appears as fine, radiating striations that extend from the peripheral retina toward the optic nerve head. This layered texture reflects the organized bundles of ganglion cell axons coursing toward the disc. In a normal eye, these striations are most easily appreciated in the superior and inferior regions, where the RNFL is thickest and therefore most reflective. Knowing what's normal here will help us appreciate the subtle signs of RNFL loss, which we'll get into next. When glaucoma affects the RNFL, those fine, bright striations we just talked about begin to fade. The RNFL thins and becomes less visible under red-free illumination. This thinning can follow two distinct patterns. Diffuse RNFL loss appears as a generalized reduction in brightness. Everything looks a bit dimmer, but because there's no sharp contrast, it can be subtle and easy to overlook, despite being the more common form. In contrast, focal RNFL loss presents as a clearly demarcated, arcuate or wedge-shaped dark zone radiating from the optic disc. These defects are easier to recognize because they stand out more dramatically against the surrounding retina. In the image here, you can appreciate an example of focal loss. The nerve fiber layer is thinned along a specific arcuate bundle, seen as a dark wedge extending from the disc. Being able to distinguish these patterns is essential for detecting progression early, especially in eyes that may still look clinically quiet. So now that we've seen how RNFL loss can appear clinically, let's talk about how we actually detect it. There are a few key methods. Historically, high-contrast black and white photographs could reveal early RNFL loss, especially in skilled hands. However, this technique has largely fallen out of favor due to the emergence of more advanced imaging tools. Today, during a clinical exam, we rely on a red-free filter paired with a wide slit beam to highlight RNFL striations. This is still a useful tool, especially at the slit lamp or with indirect ophthalmoscopy. But the most powerful and widely used method in current practice is optical coherence tomography, or OCT. This technology provides objective, quantitative measurements of RNFL thickness, allowing for early detection and longitudinal tracking of progression. With OCT, we're able to detect glaucomatous damage even before functional loss shows up on a visual field. Now that we've looked at how RNFL loss is detected and quantified, let's talk about atypical appearances that might suggest underlying glaucomatous damage. One key area to focus on is peripapillary atrophy. This refers to changes in the tissue surrounding the optic disc, and it's divided into two zones. The alpha zone shows irregular retinal pigment epithelium, RPE, pigmentation, and can be found in both glaucomatous and healthy eyes. The beta zone, however, is more specific to glaucoma. It involves atrophy of both the RPE and the underlying choriocapillaris, exposing choroidal vessels and sclera. The clinical importance of the beta zone lies in its correlation with areas of neuroretinal rim thinning. In general, the greater the beta zone atrophy, the higher the likelihood of glaucomatous damage. Aside from peripapillary atrophy, there are other optic nerve signs that may suggest glaucoma. Look for nasal displacement of vessels, narrowing of peripapillary vessels, and baring of circumlinear vessels. Over time, the optic cup can also become pale and more deeply excavated as damage progresses. These changes serve as important structural clues, especially when functional testing is equivocal. To visually reinforce those key concepts, here's an example of peripapillary atrophy on fundus photography. This image highlights both the alpha and beta zones. The black arrows are pointing to areas of beta zone atrophy where the retinal pigment epithelium is absent and the underlying choroidal vessels and sclera are clearly visible. This region, as we mentioned earlier, is more specific to glaucomatous damage and tends to align with zones of neuroretinal rim thinning. The white arrows identify the alpha zone, characterized by RPE modeling, irregular areas of hypo or hyperpigmentation. While this zone can be seen in normal eyes, it's the extent and presence of the beta zone that raises suspicion for glaucoma. Now that we've reviewed structural hallmarks of glaucomatous damage, including disc hemorrhages, rim thinning, RNFL loss, and peripapillary atrophy, it's equally important to recognize what isn't glaucoma. Some optic nerve appearances can mimic glaucomatous cupping but arise from entirely different processes. On this slide, we highlight a few key conditions that should stay on your differential when the optic nerve doesn't quite match the clinical picture. Examples include congenital anomalies like optic nerve pits, coloboma, and morning glory disc anomaly. Other conditions like ischemic optic neuropathies like AAION, compressive lesions, and optic nerve head drusen may show pallor or disc elevation, but with a very different underlying mechanism. The distinction often comes down to the pattern of pallor and cupping. Pallor of the rim without cupping should raise suspicion for non-glaucomatous optic neuropathies. On the other hand, cupping with pallor, particularly within the cup, sparing the rim, is more characteristic of glaucomatous damage. This slide is a reminder to take a step back and think broadly, especially when the optic nerve appearance or clinical history seems atypical. When evaluating the optic nerve head in glaucoma, the key principle to remember is that a single exam is often not enough. There's significant inter-individual variability, which means that what's normal for one patient might be concerning in another. That's why longitudinal documentation is absolutely essential. Now, let's talk about the limitations of some common methods. The cup-to-disc ratio by itself isn't reliable. It can vary widely between observers and even within the same patient, depending on lighting or dilation status. Additionally, drawings and written descriptions often miss subtle but clinically important changes over time. Instead, we rely on best practices for documentation. Stereophotography is the gold standard for accurate sequential monitoring. It gives us a 3D view of the disc. If stereo isn't available, monoscopic photography is still preferred over drawings. On top of that, quantitative imaging tools like OCT offer objective, reproducible data that can highlight progression more clearly than the human eye. Here's the clinical pearl. Whenever possible, use objective imaging, especially photos and OCT, over drawings. These tools offer a more reliable way to track glaucoma progression over time. Optical coherence tomography, or OCT, plays a vital role in the evaluation and management of glaucoma. Its biggest strengths are in its reproducibility, high resolution, and ability to detect progressive structural damage over time. Using age-adjusted normative databases, OCT allows us to objectively compare a patient's retinal nerve fiber layer, optic nerve head, and macula to healthy controls. That makes it incredibly useful for both diagnosis and monitoring of disease progression. The core principle behind OCT is low coherence interferometry. This uses light, not sound like ultrasound, to generate cross-sectional images. While time domain OCT is now outdated, spectral domain OCT is the current standard due to its faster acquisition, improved resolution, and superior reproducibility. There are other imaging technologies as well: confocal scanning laser ophthalmoscopy and scanning laser polarimetry. But OCT remains the most widely adopted, especially in well-resourced settings. In contrast, photography is still commonly used in more resource-limited environments. Clinically, OCT helps us measure RNFL thickness, optic nerve head topography, and macular thickness. These parameters are crucial for diagnosing glaucoma and detecting its progression over time. When we evaluate OCT scans, image quality is absolutely critical. Let's break this down into two key steps. Step 1 is image quality assessment. Most devices rate scans as good, borderline, or poor. Poor quality scans should always be excluded, as they can lead to inaccurate interpretations. It's important to remember that these quality scales vary depending on the manufacturer, so familiarity with your specific device matters. Step 2 is segmentation accuracy. This refers to how well the software identifies key retinal layers, particularly the RNFL and ONH boundaries. Each OCT vendor uses slightly different segmentation algorithms. If the scan is missegmented, say the RNFL layer is drawn too thick or too thin, it can throw off the entire interpretation. These scans must also be excluded. Finally, let's talk about sources of error. Low signal strength is a common culprit and can come from things like cataracts, high myopia, corneal opacities, or even a poor tear film. Patient movement, blinking, or artifacts can also interfere. All of these issues can lead to falsely low RNFL values or generate false positives for disease progression. So, in summary, always check both the image quality and segmentation lines before making clinical decisions based on OCT data. When evaluating the RNFL using OCT, there are several key considerations to keep in mind. First, the measurement technique. Most OCT devices use a 3.45 mm diameter peripapillary circle scan to assess RNFL thickness. This specific diameter is chosen because it helps minimize artifacts from optic nerve head size, high myopia, or peripapillary atrophy. Next is interpretation. RNFL thickness naturally declines with glaucoma. The two most commonly used metrics are the global average RNFL thickness and sectoral values, like quadrants or clock hour segments. These give us a spatial sense of where nerve fiber loss may be occurring. In terms of diagnostic utility, the global RNFL average has the best sensitivity and specificity, particularly in combination with the inferior and superior quadrants. These are typically the first to show glaucomatous damage. That said, localized RNFL defects can sometimes be missed when relying solely on averages, which is why careful visual inspection of the deviation maps is essential. Lastly, modern OCTs provide 3D RNFL maps, which enhance our ability to detect subtle or localized arcuate defects, especially useful in early glaucoma. So, in summary, peripapillary RNFL scanning provides robust, reproducible data, but accurate interpretation requires attention to both global and localized patterns. When evaluating the optic nerve head with OCT, we're focusing on topographic measurements that give us structural detail beyond what we can see on clinical exam. First, the key parameters. OCT can measure the overall ONH area, neuroretinal rim area, and cup-to-disc ratio. Because of its high resolution, OCT allows for more precise delineation of the optic nerve head's borders. Now, let's break down the anatomy used in these measurements. The Bruch's membrane opening, or BMO, is considered the true anatomical edge of the optic nerve head on OCT. From this border, we measure the minimum rim width, MRW, which is the shortest distance from the BMO to the internal limiting membrane. This measurement reflects the true rim tissue that contains axons. The neuroretinal rim thickness refers to the region between the BMO and the MRW, forming a more anatomically accurate rim boundary than traditional methods. There are several advantages to using BMO-MRW. It's less affected by variability in identifying the disc margin. It reduces the subjectivity seen with older techniques that relied on scleral landmarks. And it may improve sensitivity for detecting glaucoma, especially in early or borderline cases. So, the take-home point here is that BMO-based measurements give us a more consistent and anatomically accurate way to assess glaucomatous optic nerve damage. When evaluating glaucoma, the macula is often underappreciated, but it plays a key role. The macular region contains over half of all retinal ganglion cells, making it an excellent site for detecting early glaucomatous damage. Because it's densely packed with ganglion cells in their axons, even small changes can reflect significant disease progression. Interestingly, we now know that glaucoma frequently affects the macula early, sometimes before peripheral field loss is detectable by standard visual field testing. This can result in subtle central or paracentral defects that would otherwise go unnoticed. OCT is particularly useful here because it allows us to assess both overall macular thickness and the thickness of specific inner retinal layers. That gives us a more targeted view of glaucomatous damage. However, it's important to remember that different OCT machines analyze macular layers differently. Some provide the thickness of the ganglion cell layer, plus the inner plexiform layer, while others measure the ganglion cell complex, which also includes the RNFL. One key clinical point. In patients with high myopia or significant peripapillary atrophy, where peripapillary RNFL scans may be less reliable, macular imaging often gives more dependable data for diagnosing and monitoring glaucoma. When we talk about detecting glaucoma, it's important to recognize that diagnostic performance across RNFL, ONH and macular parameters often varies widely across studies. One key reason is the variability in study criteria, especially how glaucoma and control groups are defined. Differences in inclusion criteria and the characteristics of the study population can significantly impact how sensitive or specific a given parameter appears. Another critical factor is the role of reference criteria. For any diagnostic study to be meaningful, we need clearly defined and appropriate standards for what constitutes a case and a control. Most commonly, studies define glaucoma cases based on the presence of visual field loss along with compatible optic nerve head damage. But this approach has its limitations. For example, studies that rely heavily on ONH assessment might be more likely to detect changes in disc rim or cup shape, but may underdetect more subtle RNFL defects. This can skew the perceived utility of different diagnostic tools. Controls also pose challenges. Many studies require control subjects to have a normal-looking ONH, but that can introduce bias by excluding subtle structural variants like tilted discs, which are not necessarily pathological but can still impact measurements. So when interpreting glaucoma studies, especially those comparing different OCT parameters, it's essential to consider how the populations were selected and how glaucoma was defined. This slide shows a few other caveats when trying to detect glaucoma on OCTs. Imaging plays an important role in glaucoma detection, but it's more effective for identifying moderate or advanced disease than the earliest stages. Many studies focus on distinguishing normalized from those with well-defined field defects, which means subtle early glaucoma can be harder to detect. Prospective studies show OCT can detect RNFL abnormalities years before measurable visual field loss. One study found these changes in about a third of patients up to 5 years before their first field defect. RNFL thickness measurements can also predict future visual field loss in glaucoma suspects. This underscores OCT's value as a tool for early detection, monitoring, and predicting disease progression before functional vision loss becomes apparent. Once glaucoma is diagnosed, the next critical task is monitoring progression, primarily through structural imaging of the RNFL, optic nerve head, and macula. Progression rates can vary significantly between patients. Some experience slow structural loss over years, while others show rapid deterioration that requires prompt intervention. OCT is particularly useful here due to its excellent short-term reproducibility, but it's essential to account for long-term variability, which can be influenced by test conditions, aging, or measurement noise. To aid in this process, many devices incorporate progression analysis software, which uses age and race-adjusted normative databases to detect statistically significant change over time. A few key points to emphasize. Accurately identifying true progression means we must distinguish it from natural aging or test-retest variability. RNFL thinning may occur before it crosses into outside normal limits, so it's important to watch for subtle but consistent downward trends. The Bruch membrane opening remains a stable anatomical reference, but while BMO-MRW can be sensitive, it may also produce more noise. Critically, RNFL thinning is correlated with faster visual field loss and worsening vision. Ultimately, detecting fast progression early allows for timely treatment escalation, which is essential for preserving long-term vision. The lamina cribrosa plays a central role in glaucomatous damage. It's the site where retinal ganglion cell axons exit the eye, making it particularly vulnerable to injury. Structural changes in the lamina cribrosa are believed to occur early in the disease process, potentially even before we see classic optic nerve cupping. Historically, this deep structure was difficult to visualize until the development of enhanced depth imaging OCT and swept source OCT, which uses longer wavelengths to achieve better tissue penetration and reduced scattering. These technologies have enabled visualization of deeper optic nerve head structures, helping us better understand and track glaucomatous changes. In glaucoma patients, key imaging findings include posterior displacement of the lamina, changes in laminar thickness, and focal defects, which often correlate with areas of functional and structural loss. From a clinical standpoint, these focal laminar defects may serve as early structural markers or even predictors of visual field loss. Imaging of the lamina cribrosa could play a valuable role in diagnosing and monitoring glaucoma progression. However, the temporal relationship, whether damage to the lamina leads to neural loss or vice versa, remains an area of ongoing research. This figure illustrates the structural differences in the optic nerve head between glaucomatous and normal eyes, both in fundus photographs and cross-sectional OCT imaging. At the top, we see color photographs of the optic discs. Panel A shows a glaucomatous disc with visible cupping and neuroretinal rim thinning. Panel D shows a healthy optic nerve with a well-preserved rim and smaller cup. Moving down to the OCT scans, panels B and C show enhanced depth imaging, EDI OCT, and swept source, SSOCT, scans of a glaucomatous optic nerve. Notice the posterior displacement of the lamina cribrosa and thinning of the neuroretinal rim. In contrast, panels E and F show normal optic nerves with a more anteriorly positioned lamina cribrosa and thicker rim tissue. The green lines highlight the anterior border of the lamina cribrosa across all scans, making it easier to appreciate the structural changes. Together, these images underscore how advanced imaging modalities like EDI and SSOCT allow us to visualize deep ONH structures, helping us detect and monitor glaucomatous damage more precisely. As we wrap up our discussion on structural imaging in glaucoma, it's important to touch on a more recent advancement, optical coherence tomography angiography, or OCTA. Unlike traditional OCT, which provides detailed structural measurements, OCTA evaluates microvascular changes in the optic nerve head, retina, and choroid. It does this by analyzing motion contrast between repeated OCT scans to detect blood flow without needing dye. The key parameters here are vessel density, which reflects the proportion of image area occupied by blood vessels, and flow index, a proxy for signal strength in flowing blood. In glaucoma, we often see reduced vessel density and flow, and studies show these vascular reductions can correlate with visual field loss. That said, OCTA still has its limitations. It's sensitive to motion and projection artifacts, and while promising, it remains uncertain whether OCTA outperforms conventional RNFL or structural OCT in clinical decision-making. So while OCTA adds another layer of insight, especially in research settings, it remains complementary to, rather than a replacement for, standard imaging. Thank you all for your attention throughout this presentation. We hope the material provided was informative and thought-provoking. Please take a moment to review the reflection and discussion questions included at the end of the slide deck. These are designed to encourage deeper understanding and clinical application.